Okay, is it better? Yeah, all right. And I'll talk a little bit about alteration in plant phenology. And I'm going to give you a national perspective, so to speak, on how changes in plant phenology may impact human health. Okay, and if we have a little bit of time left, I'm going to give sort of like a local perspectives, and on that I'm going to talk about the impact of extreme heat events on adverse health in Maryland. So I'm going to touch a little bit on asthma hospitalization, myocardial infarction hospitalization, and salmonellosis. So this is going to be a little bit different from the phenology work in that this is related to extreme heat event. And hopefully we'll have some time for questions and discussion. I thought I will start with this graph here that's showing you the temperature in the land over our northern hemisphere from 1951 to 1980. And I'm sure like a lot of you have seen some variation of this graph, and on the x-axis is you have like standard deviation. So a lot of the temperature falls within, that 3 standard deviation, nice bell-shaped curve. But if you look at how things are happening, this is looking at now 91 to 2001, that entire distribution is shifting rightwards as our climate is changing, right? So where you don't have any, like very little observation beyond 3 standard deviation, you start seeing a lot of occurrence of these extreme heat events, okay? If you look at 2001 to 2011, it's shifted even more towards the right. And this is what we talk about in the context of climate change, that whole paradigm, the distribution shifting rightward. The challenge of linking climate change to human health is that, like I just showed you earlier, climate change happens on a very slow scale, right? I mean, it's like a decadal phenomena, like a very, 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 very slow changes. Whereas human health is, like very, like short duration. If you say like asthma attack, you had an asthma attack and you went to hospital yesterday, right? Or your child had a, asthma attack in the school last year, whatever. How do you link something that's so, like transient in nature to something that happens over a decade? I mean, so the differences in temporal scale of the outcome in this case, like respiratory diseases, linking those two things that happen more on the decadal scale. And to complicating matter, like most of the epidemiological studies, you are lucky if you get 5-year study by NIH, right? So like most of them like 2-3 years. So you have epidemiological studies that last like 2-3 years, 5 years, maybe looking at health outcomes that are transient, but you are trying to link it to something that happens more on the decadal scale. So that's a challenge. And we also, in epidemiology, we tend to use metric to describe exposure that relies on, like concentration of the agent, whatever the hazard is, how long were you exposed to, and what was the frequency of exposure to that agent, right? So like none of this traditional measure sort of like applies to when you start thinking about climate change. So a little bit of framing is required, right? And we know that the extreme events are, like rising in response to our changing climate. We also know, based on overwhelming scientific literature, that the frequency, intensity, and the duration of these extreme events are projected to increase. So in other words, they are projected to become more intense, longer lasting, and nastier in the decades ahead in response to our changing climate. So what we do is like switch the question a little bit and then start asking, how does the frequency of extreme event impact human health? Right? So it's a little bit reframing. You may also start thinking about things such as plant phenology. Okay, so for those of you who are not familiar with plant phenology, although I doubt in this crowd, plant phenology is what we call nature's calendar, and it deals with, for example, timing of seed germination, timing of leafing, when the trees start turning green in this area, timing of particular flower blooming, for example, cherry blossom, when does it bloom, right? Growing season length, like per the entire season. So these are all examples of plant phenology. And it turns out these are also the most sensitive indicator of ecological response to our changing climate. So this is how ecology responds to our changing climate, okay? So the question then becomes, how does alteration in plant phenology affect our health? In this case, what I'm going to present to you is allergic diseases. How does, when those phenology changes, because they are the most sensitive indicator to our changing climate, what does that do to our health? Okay? So that's basically the framework. And I just wanted to start with some of this data. This is the work of one of my collaborators, Dr. Lou Jiska, who is at USDA. And he did this really nice chamber studies, control experiment, where he grew ragweed plant in a differing concentration of carbon dioxide. Okay, so 280 part per million, which is roughly where CO2 concentration in the pre-industrial days, and then 370 part per million, that's when it was 2000. Of course, we have far exceeded that right now. And then what was anticipated at that time to be in 2075, like 720 part per million. So these are all controlled experiment chamber studies where he is growing ragweed plant at that or those different concentration. And what he showed was the number of pollen production, this is grams per plant, was much higher in a higher carbon dioxide concentration. Okay, so it's very interesting. Like, so the same ragweed plant, the pollen per plant is much higher. Ragweed produces much more pollen on a higher carbon dioxide concentration. This is another study where he was looking at pollen season length. Okay, so how long does the ragweed plant produce pollen? Okay, and this is, he was comparing 1995 to 2010. And what he showed in this study was between that, like 14, 15-year duration, the ragweed pollen season had increased considerably. But what was more interesting was the increases on the length of ragweed pollen season was much more pronounced on the northern region compared to, middle of the country. Okay, so this is really, really interesting. If you are particularly somebody who suffers from asthma or allergic diseases and so forth, like the longer pollen season, meaning you are exposed to ragweed pollen, which is absolutely nasty for longer duration. This is another study. This is sort of a natural experiment where he is growing ragweed in downtown Baltimore, in the Towson, like on a suburban location, and in the rural farm. Okay, so what you are looking at is ragweed pollen, grams per meter cube on the y-axis, and the length of pollen season. Okay, this is the calendar date. Okay, so comparing rural site to urban site, the same ragweed plant grown on downtown Baltimore produces a lot more pollen. Okay, produces a lot more pollen. But not only that, the length of pollen season is much more longer compared to if you look at even the semi-urban or the rural farm site. So what is in downtown Baltimore that is not in rural site? First of all, the temperature is warmer because of the urban heat island, right? And downtown environment we know contains higher concentration of carbon dioxide because you have a lot of industry, but you also have a lot of vehicle exhaust. And the vehicle exhaust is a major source of carbon dioxide in the urban environment. So this sort of tells you the things, how things will be on the changing climate, even when you are just looking at ragweed plant itself. Okay? And this is a little bit different. You're looking at allergenic level of trees, this is how it's at present, and the projected increases under low emission scenarios in 2100 and the high emission scenarios in 2100. So like it's going to be much more different, irrespective of whatever the scenario is. So this sort of like provides us this idea that it's concerned from human health perspective, okay? But what we do not have is the empirical evidence, the quantitative estimate. how much effect are we going to have? How much effect is there, right, when such type of changes do happen? That quantitative estimate is lacking. And if it is present, who are the most vulnerable people? Not everybody is going to respond in a similar fashion, right? Who's going to be the most vulnerable people? Where do these most vulnerable people live? Okay, because we want to identify those most vulnerable people, because in the public health, we are all about intervention. Because if we know where these people live, then we can sort of like start planning adaptation strategies, targeted intervention to minimize the effect. So that knowing where these people live is very, very critical. And we can do this by leveraging existing large data sets. Okay, to do this type of studies and new studies is very, very, very difficult. So the action is very much at identifying what sort of database is already there and leveraging those data sets. And you see what is out there and conceptualizing your problem and really asking the right question. And there are such data sets that provides both that spatial and temporal contrast in exposure. Okay, large data sets do exist. So for a phenology data, you can use, there are in situ measurements. This is actually people going and recording this phenology, actually going and making those observations. But better, there are remote sensing database. These are satellite data used for tracking seasonal changes in vegetation at local, regional, national, and global scale. And the beauty of this sort of like remote sensing data is it's consistent, right? So you don't have to worry about one group using this sort of methodology, other group using another sort of set of methodology. It's consistent on the methodology, and it's consistent on the spatial resolution as well. So there's definitely benefit to using that sort of data. And there are many phenology products available, but the one that we are primarily using is MODIS data. So just to give you an example, if you look at the vegetation coverage from satellite, this is a normalized differential vegetation index. In the winter time, you see like a lot of gray because you don't have leaf, right? So same NDVI measure on the spring, like where things have really greened up now. So you can see that intense greening. And then summer, the intensity increasing, and the fall, your foliage starting to turn color. So if you do a time series of this NDVI measurement, then by looking at the rate of change on this NDVI measure, you can start identifying when the spring started. Okay, so what we call the onset of spring or onset of greening. And this is nice in the sense that this information is available to like pixel, 250 meter pixel if you're working with the MODIS data, okay? And we can, using that whole, like 12, 13 year, 14 year worth of data, then sort of like estimate for each of the county. It's, like because in a lot of health data, we start working with the county level. When does on average, when the spring starts? For the health data, you have database such as National Health Interview Survey. This is the CDC data, the CDC survey that has been done since 1957. Okay, so anytime you hear the obesity, prevalence of obesity in the extreme obese people in the United States is 33% or 36%, and how it's changing over time. Or the rate of asthma in Puerto Ricans are so and so percent. All of that information is coming from this data set. Okay, so these databases, like the sources of a lot of this national statistics, where it comes from, surveys like the National Health Interview Survey, as well as the National Health and Nutrition Examination Survey. So this is a cross-sectional survey, and surveys are conducted continuously throughout each year. And every year, CDC does about 35,000 households. That translates to approximately 100,000 people per year. Okay? And the beauty of that information is we not we, but the CDC knows exactly where those people are. Okay, they know their address. So we have collaborators in CDC who have geocoded all those data dating back to 1990. So you have like very well geocoded data that is available. Of course, you have to go to CDC, to the Research Data Center, to use it. But nevertheless, that's a very, very, very rich sources of health data. Okay, and there's a very good temporal coverage, very large sample size. This is everything that epidemiologists dream of, right? And it has health outcome on that, like ranging from outcomes like allergic rhinitis, which is hay fever. Like it's not severe, but like if you suffer from it, it can be, like quite annoying. And in some, if you have asthma, it can, it can be much nastier. And roughly 8% of the U.S. suffers from allergic rhinitis. Okay, and it costs U.S. economy close to $12 billion a year in terms of, like healthcare cost, loss of productivity, and so forth, right? So this is important. It's not a very serious disease, but yet it's important from the economic and like that if you are suffering from it. So what we do is then we merge the National Health Interview survey data with the MODIS phenology, and our outcome, like I said, is allergic rhinitis or hay fever, and the exposure metric that we are looking at is changes in the onset of spring. Okay, just that one data point on that time series. And the time period we are looking at is 2001 and 2013, because that's when the MODIS data became available. So for this analysis, we have close to 400,000 respondents. Okay, so like very large data sets in this case. And each of the onset of greening, we look at for each respondents in the location where they are living, how early or how late was the start of spring on the survey year that they were sampled. Okay, so we have a long-term average, and then for the survey year that they were sampled, we asked them how early or how late did the onset of greening happen, or how early or how late the spring arrived, right? And then we categorize that changes, that deviation in the phenology into 5 groups, okay? So if it arrived within 1 week of that long-term norm, either like 1 week early or 1 week late, we call that normal. Yes?
Is the long-term norm for spring from different data set from the
MODIS.
MODIS data set? So it's the average over that
2013 for that particular pixel where that respondents live. So each has their own. Okay. So if it arrives, so then early we have like if it arrives greater than, very early is greater than 3 weeks early. Early is 1 to 3 week early. You have normal. Late is 1 to 3 week later. Very late is 3 weeks late, greater than 3 weeks later. Okay. So we categorize them. And then we use logistic regression in Sudan to account for the complex survey design. And we adjust for many known confounders for these diseases. We know age, race, sex, ethnicity, smoking status, whole host of individual level confounders are available. Okay, that's the beauty of this survey. I mean, it's like every observation is at individual level. So this is basically the demographic characteristics of that study population. Okay, like age group, race and ethnicity, poverty. This is the timing of like greenness and changes in plant phenology as categorized by that among people who did not have hay fever and people who did have hay fever. Nothing terribly exciting there. This is one of the main results. So where I'm showing you odds ratios and 95% confidence interval. So the odds ratio is basically ratio of disease among people who are exposed to the odds of disease among people who are not exposed, or in this case, the normal category. Okay, so everything gets compared to that normal, okay, 1 week early to 1 week late. And we call that the reference category. So everything else gets compared to that. and this gets compared to that. Okay, so just to walk you through it, so if you look at this very top here, so when you compare individuals that live in an area where the onset of spring was greater than 3 weeks early to people living on the area where the onset of spring was normal, we see 14% higher risk of hay fever. Okay, so the prevalence of hay fever was 14% higher among people who live in an area that was characterized by greater than 3 week early onset of spring. Same way, if you look at people living on the area where the onset of spring was greater than 3 weeks late, we see 18% increase in risk of hay fever. It's really interesting. So risk is high if the spring arrival is early. Risk is high if the spring arrival is yes.
Sorry, you explained earlier, but which variable from all this data set do you use as a proxy for early arrival of the spring?
So it's all based on the NDVI.
Just NDVI.
Mm-hmm. Yeah.
And that somehow relates to plant phenology.
So NDVI measure is used, I mean, the variable that we use is actually start of spring, okay? And that start of spring is derived using the time series of NDVI measure. And this is actually publicly available data set. You can download this data directly from USGS. So everything is publicly available except the health data. So this is really interesting, So then we looked at, so that's for the overall population, right? But then we look at different groups. So this is like age groups. So this is red is very early, black is very late, and the others are in between. So greater than 65, you see the most action there, and then we divide by male and female. We divide by race. This is non-Hispanic white. This is non-Hispanic black, and Hispanic. The increases in, risk are more pronounced in non-Hispanic black and non-Hispanic compared to non-Hispanic white, right? And we also looked at the size of the county, urban-rural status. The most pronounced effect are on a suburban area. But rather than focusing on those details, what I want you to look at is the shape. Okay, so the shape of this exposure response curve. Everything's sort of like a U-shaped curve, okay? And in that, the early onset is a risk, late onset is a risk, and somewhere in between we like, okay? Same idea on if you look at heat wave mortality, heat and mortality literature. Very cold temperature kills you. Very hot temperature kills you too, as we found out with the European heat waves. Like close to 60, 70,000 people died during that European heat wave, something like 10 years ago. I think 10, 12 years ago. So very cold kills you, very hot kills you, but somewhere in between, there's a sweet spot, and we all like. So similar pattern is emerging on this, right? So what we have shown with this data is, really application of this remote sensing on existing health data set that are collected using the taxpayer dollar, okay, application of those data sets. And when you merge those things, that it enables you to ask these questions that the designer of those data sets never even dreamed of, they never even thought of, right? So that's really where the action is, like leveraging those large data sets to ask these novel questions. So in this context, how do we explain what we just observed? And to explain that, I just want to spend 30 seconds, explaining this. Talking about this side note. And remember, like when I talked about early, towards the beginning, how epidemiologists measure exposure, we look at frequency of contact, right? How often are you getting exposed to the agent or the hazard? That's one way to measure it. Another is we look at the duration of exposure. How long were you exposed to? Were you exposed for a few hours, or were you exposed for years, or were you exposed for 1 week? That all depends, that drives risk, right? The duration of exposure. And the last one is concentration of the agent. How bad is the concentration? How high the concentration is? Is it very low concentration or very high concentration? So I think we can explain our finding in this context. So very early onset of spring, does appear to be a risk factor for hay fever. And I think what is happening is longer duration, so when the spring arrives early, so your duration of exposure to pollen is long. So you are exposed to pollen for a longer period of time, right? So you have more chances of having that allergic reaction to it, right? So the duration of exposure is lengthened when the spring starts early. The tree starts blooming early and early, so your pollen exposure starts very early on. We were not expecting to see this, that the later onset of spring also appeared to be a risk factor. And going in, we were not expecting this at all. But then we started thinking about it, how could that be? But on the hindsight, it does make sense, right? So when the spring arrives very late, the duration of exposure to pollen may be shortened. But as you remember last year when the spring arrived rather late, all of a sudden, all the trees go gangbuster at the same time. Everything starts blooming at the same time. So you are inundated with the pollen, right? So the exposure duration may be very short, but you are getting exposed to much higher concentration of pollen. Okay, and that's important. So I think that's why we are seeing that. That the first one, the early onset of spring, lengthens your duration of exposure, but the later onset also contributes to the risk by virtue of increasing the pollen concentration in the environment, because all the trees are all of a sudden blooming together at the same time. Yes, Margaret?
Can you assume there's an infinite amount of pollen, so that earlier onset of spring means also flowering continues and pollen production continues longer?
We don't. I don't know. I don't know. But I think it's like some species are flowering early, and then the others, there's continuum of that, and so it's like happening over a long period of time, as opposed to like when it's short, like all of a sudden everything is blooming at the same time. And we are actually trying to look at some of these things from the mechanistic side. So we are trying to get pollen data, and it's. You may think it's pretty easy, but it's ridiculously hard to get this pollen data, and at least for the United States. So I'm talking with somebody at Canada who has access to a lot of the data from the Canadian network, and hopefully we can test our hypothesis from the mechanistic side using the ground pollen measurement. Yes?
So could it be, do you have an idea how much that could compare to other environmental factors? For example, if it's raining a lot, it's going to keep the pollen to the ground.
Mm-hmm.
Or if it's a dry season,
Mm-hmm.
it could also increase kind of exposure to dust mite, which has the same symptoms.
Mm-hmm, mm-hmm. Well, there's definitely the truth to that. The question is, like, if it rains, then obviously it, settles all the pollen into the ground, so it clears the air. And we haven't looked at that on this particular context. Okay, but your question is very valid. Other questions on this before I switch gear? Let's see how we're doing on time. I think you have a little bit of time. Okay.
One more question from that. I don't quite understood. If you're saying your baseline for the seasonal, or the average for the seasonal onset or start of spring is from that modus time series.
Uh-huh.
Do you think that would lead to biasing your estimate of the effect quite a bit? Because if the distribution is shifting right, at least at the regional scale and the climate change, and you're measuring the start of spring onset change against the shifting distribution versus maybe ground truthing it in particular places with historical records of when spring started. I'm thinking stuff like where people journaled in New England about when spring started in the 1800s.
Mm.
Maybe then you've got a much better baseline for kind of pre-climate change seasonal onset. You might see a much stronger effect.
I think it'll be nice, but remember we are working with the MODIS data, so the earliest is like 2000 basically, but it's the shift itself. Like remember, this is within like 12, 13 year period. So it's not like a whole big shift we're talking about. It's like a lot of it is more of a variability, year to year variability, right? So I think it'll be a little while before we can actually start talking about the decadal shift. There are other satellite, I think like the AVHRR product that are available from the 80s that you could probably use to look at the shift itself. But then that poses a question about the health data that hasn't been geocoded up to that. But I think some of the things that you are bringing up is a very interesting question that we need to look at. This is the first cut at this.
Just really quick, I'm just curious, like, to me this seems to imply that people kind of develop a tolerance to pollen in their area, right? Because people in different parts of the country are exposed to spring at very different times, but you're doing it based on the average within a pixel deviations from that.
Exactly.
Climate change happens slowly, kind of as you noted, so is shifting the distribution, would people just kind of get accustomed to a new mean and not necessarily have more hay fever if temperatures are rising, but what they're really impacted by is increased variability of when spring starts?
I don't know to answer your question, but I think it's important to not get lost. Like this is, remember, like I said on very earlier, this is an indicator, like a ecological response to our changing climate. I'm not, like saying you can't really, based on this kind of data, definitely say this is shifting and this is what we are seeing, if that's what you are trying to infer to.
No, not directly inferring that. Yeah, trying to get a sense of, since it's deviation from the normal in a certain spot, is it basically that people get used to?
They get adapted to their new. That's a good question, and I don't know. Some of the things, like they may be, if you look at, like heat wave literature and mortality, right? People who die from heat wave, like the heat wave that happened earlier in the season, like May, June, kills a lot more people than heat wave that happens in August. Because there's two things involving on it. One is people have adapted to higher temperature throughout the summer, right? And then the other is because those that are most vulnerable have been cleared up by the early onset of heat waves. So similar could be like adapting to it could apply to this, but we don't have the data to answer that. Like our data doesn't get into that.
I just have a comment. In the tropics, where you don't have such defined seasons, the spring, whatever, in terms of phenology, the plants, they bloom and there's pollen production all the time, but the intensity is not as high. So to me, it indicates that, in the earlier onset of spring, when you have as a risk factor, maybe it is a combination of longer duration of exposure, but the intensity is also a factor, because in the tropics, you don't hear so much about hay fever. Even though we're exposed to pollen all the time, there's always some flower blooming somewhere. So anyway, it's just an observation.
Okay, great. Thanks. All right, so I think in the next 10 minutes or so, I will quickly give you some examples, like Maryland-specific examples related to extreme heat event in this case and effect on health. Remember earlier I was talking about, like posing question from a little bit different perspective on that, looking at how does the frequency of extreme event impact health. So to do that, we have partnered with the Maryland Department of Health and Mental Hygiene through a grant funded through CDC, where we are looking to characterize, how this extreme event may be impacting the health of Marylanders. And we're looking at whole host of health effects, including asthma, hospitalization, heart attack, salmonellosis. This is respiratory disease, cardiovascular disease, and foodborne diseases. And we have data from 2000 to 2012. We have close to 116,000 asthma hospitalization, almost 139,000 of heart attack in Maryland during that period, and like 9,500 salmonella cases. And for this work, we define extreme heat and extreme precipitation event using 30-year baseline. That was from 1960 to 1989, so 13-year baseline, and we just use those baseline data that is specific to a given county and a calendar day to identify extreme heat event and extreme precipitation events. So when we do that, similarly using time series analysis, in this case we are actually using case crossover analysis, and we're looking at extreme heat event and asthma hospitalization for Maryland. And this is for the entire year, and then this is for summertime extreme heat event. What we see is during summertime, extreme heat event contributes to 23% increase in risk of asthma hospitalization in Maryland. Okay, and this varies by different race and ethnic subgroup. Blacks have much I think, what is it? And it varies by county. So if you look at Baltimore City, like the risk is, instead of being 23%, it's almost 36%. Washington County has a 76% increase in risk of asthma hospitalization per 1 unit increase in extreme heat event. It's a big deal. Whereas some others, like the effect is less pronounced. We did the same way for heart attack. And for a heart attack, we see almost 11% increase in risk of hospitalization for heart attack if there is an extreme heat event. And this is extreme heat event happening at the same day or the day before. And what is interesting in the case of heart attack is the risk is much more pronounced, almost 27% among non-Hispanic Black compared to non-Hispanic white, where the risk is 9%. So there's a difference just based on the race and ethnicity. There's a difference based on geographic area too. For example, Baltimore City, 43% increase in risk of hospitalization for heart attack compared to Prince George's County, where we don't see effect. Washington County, we don't see effect. Wicomico County, we don't see effect. And this is what I was referring to earlier when I said that the need to identify the most vulnerable communities, okay? Because this sort of information informs, should be used to inform our adaptation strategies moving forward. We did same thing for salmonellosis, salmonella infection, and in salmonella infection we saw, a risk associated with extreme precipitation event as well as extreme heat event. Extreme heat event was increased the risk of salmonella infection by 4%, and extreme precipitation was almost 6%. But what was really interesting on this case is we tried to divide Maryland into coastal counties and non-coastal areas and non-coastal areas. This is as defined by the DNR, okay, DNR definition of coastal counties and non-coastal counties. And what we observe is when you do that, in the non-coastal area, you don't see effect of extreme heat event on salmonella infection. But in a coastal area, like 5% increase. And the 5% increase may sound small, but remember, this is 5% increase in risk of salmonellosis associated with 1 unit increase in extreme heat event. Okay, so it's quite a large risk. Same way, if you look at extreme precipitation event, the non-coastal area is around 3.6% per 1 unit increase in extreme precipitation. But in the coastal area, the risk is more close to double. Okay, so twice the increase in risk in the coastal areas. So this was, lot of literature on epidemiology has been talking about how coastal communities may be more vulnerable also from the ecological perspective too. But this was really the first evidence where we saw quantitative differences in the risk of foodborne illness by coastal communities and non-coastal communities. Okay, so just to summarize that work, extreme heat event increases the risk of hospitalization for asthma attack and a heart attack in Maryland. And both extreme heat and extreme precipitation increases the risk of salmonella infection in Maryland. And more interestingly, the risk of salmonella infection is much higher in the coastal areas, coastal communities compared to non-coastal communities. I think that is all I have to say, and we have a few more minutes, like I promised, for hopefully